Bueno, muchas gracias, doctora Malagón. Excelente exposición. Toda la clínica, toda la experiencia, ¿no? La siguiente exposición va a ser en inglés. Tenemos disponibles para traducción simultánea los equipos. Quien considere que necesite el equipo, aquí a la entrada con su documento lo puede solicitar. Quien esté cómodo escuchándola en inglés, vamos a escuchar la siguiente conferencia, que es a cargo de la doctora Sheila Angels Han. La doctora es profesora asociada y profesora asistente de oftalmología en el Centro Médico del Hospital Infantil de Cincinnati y en la Universidad de Cincinnati. Completó su residencia de pediatría en la Universidad de Illinois en Chicago. Hizo su especialización de reumatología pediátrica en el Hospital for Special Surgery y una maestría en investigación clínica de la Escuela de Graduados de Ciencias Médicas de Wales en la Universidad de Cornell. Su investigación se centra en investigar biomarcadores no invasivos y factores de riesgo genéticos de la inflamación ocular y establecer una evaluación integral de los resultados de la uveitis pediátrica. Desarrolló y validó la única medida de la calidad de vida relacionada con la visión y la función para la uveitis pediátrica mediante el cuestionario Efectos de la Vista de los Jóvenes en la Calidad de Vida, IQ. La doctora ha mandado su conferencia y ella estará conectada para resolver dudas y preguntas. Entonces vamos a continuar con Actualización en uveitis de la doctora Sheila Angels.
Good afternoon. I'm delighted to be here today to present on updates and risk factors for uveitis onset of this program. I'm Sheila Angels Han. I'm a pediatric rheumatologist at Cincinnati Children's Hospital in Cincinnati, Ohio in the United States. I'm sorry not to be able to join you all in person, but really hope to visit beautiful Columbia one day. So today we're going to talk about three major areas. One is I'm going to give a brief overview of uveitis. Then we'll talk about the known risk factors for uveitis development in children with juvenile idiopathic arthritis, or JIA. And then we'll talk about newer risk factors that have emerged over the last few years. So first the question is, what's uveitis? So uveitis stems from the Latin word for grape, or uvea. It consists of inflammation throughout all portions of the eye, so the iris and ciliary body anteriorly and the choroid posteriorly. And you can see that the eyeball is very similarly shaped to the grape. Uveitis in children can be due to many different causes, but as pediatric rheumatologists, we're most concerned about non-infectious uveitis that can be associated with different systemic conditions, and also when it's restricted to the eye, is found in idiopathic uveitis. We always have to remember, though, that uveitis can be caused by infections and sometimes can be due to masquerade syndrome. Very similar to all our other autoimmune diseases, there is an interplay of various factors that lead to uveitis development. So we know that genetics, hyperactivation of the immune system, and perhaps even the environment play a role in the pathogenesis of uveitis, but it does still remain poorly understood in children. What we know is that the eye is an immune-privileged organ, and there are two systems that protect the eye. There is an anatomical blood-ocular barrier that consists of the blood aqueous and the blood-retinal barriers, and there's also an immunologic barrier. And what's thought is that somehow this immune privilege is broken, wherein inflammation is able to bridge the blood aqueous and blood-retinal barriers, then leading to uveitis in children. Overall, the annual incidence of uveitis in North America is thought to be about 4.3 to 6 in 100,000 population, with a prevalence of 30 in 100,000. And Dr. Smith in 2009 looked at a relatively large cohort of children where there were 527 children with different types of uveitis. And what she found is that there was an equal distribution in males and females, that it was more prevalent in non-Hispanic white children, that anterior location was most common, and that most children, almost 80% of them, had bilateral involvement. When they looked at the specific diagnosis that was associated with uveitis, what they saw is that children with JIA-associated uveitis and idiopathic uveitis were more common, and a little bit less common was uveitis associated with infections, most commonly toxoplasmosis. But again, this is a North American population. It's always important for us to think about where the inflammation is located. And in the table, you see the Sunwork and Wu classification of uveitis. And we see that inflammation can occur in the anterior, intermediate, posterior, and throughout all the sections of the eye. And on the cartoon on the other side, we see that for the anterior segment, it involves primarily the ciliary body and the iris. Intermediate segment involves the vitreous humor in the middle, and the posterior segment involves the choroid and the retina in the back. And when someone has panuveitis, what we know is that all areas of the eye are involved. It's really important for us to think about where uveitis is located because the location can be associated with specific systemic diseases. So for example, in children with anterior uveitis, we tend to think about JA-associated uveitis, HLA-B27 associated, such as von Willebrand arthropathies, inflammatory bowel disease, and psoriasis, whereas children with posterior and panuveitis may have other systemic disease associations like Behçet's, Blount syndrome, or VKH. Because of the frequency of anterior uveitis in children, that's really where we're going to focus most of our talk today. So for childhood non-infectious anterior uveitis, we know that idiopathic CAU comprises 40% of the pediatric uveitis population, whereas JIA-associated can occur anywhere from 20 to 47% of that population. And in children with JIA, anywhere from 10 to 20% will develop uveitis. And again, it's anterior, it's non-granulomatous, and chronic. Both eyes are involved for the most part, and anywhere from 20 to 60% of these children will develop some form of ocular complication or blindness, and many of them have vision impairment into adulthood. In this box, I show the different JIA categories, and those highlighted in orange are the JIA subtypes that tend to be most commonly associated with uveitis. So I think what's really important for us to remember is that the majority of these children, 80% of them, are asymptomatic. Thus, it's very important that when they have JIA, these children are screened regularly by an ophthalmologist for any signs of ocular inflammation. This is especially important because children with uveitis that's untreated or is not detected early can develop ocular complications. And so we see 50% of children with JIA will have some form of complication. And I really like this cartoon because it segments the eye into the anterior, intermediate, and posterior portion and shows you where the complications are manifested. So for example, in the iris, we have the commonly found synechia. In the lens, you have the cataract. And in the cornea, what you'll have is calcium deposits or band keratopathy. So regular screening and early detection and treatment are increasingly important. So after that background, we're going to start talking about the risk factors for uveitis onset. I'm going to focus initially on those that are currently known and then move on to those that have emerged over the last few years. And as we get a little bit more excited about learning about risk factors, I'll start off with a case. So pretend you're in clinic and you're seeing a 3-year-old white girl who's had 2 months history of knee pain and swelling. On examination, you know that she has right knee arthritis, but the rest of her other joints are normal. Her labs are pertinent for ANA positivity, but the rheumatoid factor and the HLA-B27 are negative. So when you see this child, some things we need to think about, are 1, what is her risk for uveitis development? 2, what kind of risk factors do you need to consider that will inform her risk? And then what screening frequency would you recommend based on these risk factors? So this figure shows you the 4, well-known factors that increase risk for uveitis. 1 is the type of JIA, and we know that children with oligoarthritis, polyarticular rheumatoid factor negative, psoriatic, or undifferentiated JIA are at increased risk. Those who are younger than 7 years of age, and those who are earlier in their disease course, typically within the first 4 years of JIA onset, and who are ANA positive are considered to be at highest risk. There have been various screening schedules that have been recommended by the American Academy of Pediatrics, American College of Rheumatology, from EULAR, and from, globally from different countries have published local recommendations. But I think what we all agree on is that children with these JIA subtypes, the ANA positivity, young and early in the disease course should be screened every 3 months since they're at highest risk. For those with other types of JIA who may be ANA negative, older, or have had JIA for a longer period of time, their screening can change from anywhere from every 6 to 12 months, depending on the combination of those different risk factors. So studies throughout the years have confirmed and validated these same risk factors repeatedly. So I thought I'd show you this nice study by Dr. Lee in 2018, where they looked at a relatively large cohort of Canadian children. There were a little more than 1,000 children with JAA who they followed for about 3 years, and around 100 of them developed uveitis. So they confirmed the well-known risk factors that we just discussed. What they showed is that within the first 5 years of JAA diagnosis, that risk for uveitis is there, the cumulative incidence of 12.9. So again, highlighting that the first 5 years are probably the most important period of time after JAA that uveitis can occur. And then recently, in 2023, there was a group from Prinzo and the German Icon and the CAPS group, and they looked at a much larger cohort of children, and they were interested in validating a model that could predict uveitis development in children with JAA at different time points. So there were 2 cohorts. The first cohort was around 5,000 to 6,000 children, and the second cohort was about 1,400 children. And again, around 15% of these groups developed uveitis. And in this large group of children, they again validated that the young age of JIA onset, ANA positivity, and the ILR risk group categories were important. But interestingly, they didn't think that rheumatoid factor negative polyarthritis had the same risk as oligo, psoriatic, and undifferentiated arthritis. So using these findings, they tried to develop estimation models. And if you look at the top portion, we see the different JIA categories. And then over here is the ANA status, and below is the age of JIA onset. And we'll focus on this box. And what you'll see is that, so again, those with high risk categories, ANA positivity, and earlier in their course had a much greater risk of developing uveitis from the 2, 4, and 7-year risk period of time. And so they proposed changes to the screening of uveitis in these group of kids. For this particular group, they thought perhaps that screening every 2 months in the first year, every 3 months in year 2, and every 4 months in years 3 and 4 would be most important. So something for us to think about. And then aside from those known risk factors, others that have emerged recently, I think we've known about female sex for some time, race, arthritis activity, early systemic treatment, regularly drawn labs such as the SED rate, genetics, and biomarkers may actually play some sort of role and may inform our screening in the future. So for race, we know in general that non-Hispanic white children have had an increased risk for developing uveitis. There have been a few studies over the last few years that have looked at children who are African American with JIA, and what they showed is that the risk may be lower, and consistently around 8% of these children would end up developing uveitis, so very different from other races. And then early treatment has always been an important topic because we think that early treatment may actually mask the development of uveitis, especially since we treat JIA so early. So one study in 2016 by Kostick and his group looked at 251 children with JIA. 68% of them are treated with methotrexate, and 23% of them developed uveitis. When they compared the uveitis frequency in methotrexate treated versus methotrexate untreated, they showed a significant difference, whereas 11% of methotrexate treated versus 47% of untreated developed uveitis, which was significantly different. And then when they generated their Kaplan-Meier curves, the red line here are children who are not treated with methotrexate, compared it again to children who did get treated with methotrexate, and there's really a big difference in the risk of developing uveitis over time and those who are not treated. This is also confirmed by another study in 2013, where again, they looked at around 200 children, some treated with methotrexate, some were not, and then 10.5% of methotrexate treated versus 20% of untreated developed uveitis, although the p-value was not as exciting as the other study. But they generated very similar Kaplan curves, and this with the black dots are children who are not treated with methotrexate, which is very different than those who were treated. So perhaps early treatment can affect the risk of uveitis development. There have been studies that have looked at genetic risk factors associated with different types of uveitis. And for JIA associated in particular, our group previously showed that HLA-DRB11 and HLA-DRB113 increase susceptibility to uveitis, whereas HLA-DR1 is protective. And again, this has validated many earlier studies. In autoimmune diseases in general, there's been great interest in discovering and validating biomarkers that are associated with different autoimmune conditions. And in pediatric uveitis, most of these have focused on looking at biomarkers in aqueous humor and serum. Here on the left of this table are the different cytokines, chemokines, and SM100 proteins that have been reported. And what you'll see here is for aqueous humor, there seem to be some differences in these biomarkers in children with JA and uveitis when compared to other types of uveitis and to controls. Interestingly, this has been shown in some studies looking at serum, but in general, not all these biomarkers are able to be measured or even detected in serum, possibly because it is further away from the area of inflammation. So a study by Tapenier in 2018 tried to combine both things. They looked at the known risk factors and then biomarkers in a group of almost 1,000 children in Germany who they followed for almost 4 years. And again, about 14% of these children developed uveitis. What they showed is that, again, the ANA positivity and early age of JA onset were significant, but when they looked at different markers, an elevated SED rate and S100A12 early in the disease may be associated with uveitis development. And later on at follow-up, again, this elevated SED rate may be important. So those are some of the serum fluid biomarkers, but considering the location of the eye, the general thought is that ocular fluid biomarkers would be most important. And most studies have looked at aqueous humor, which is the gold standard. But collection of aqueous humor is invasive and not feasible in most children. And now we know that blood may not accurately reflect ocular inflammation, so it isn't able to detect all the different biomarkers. So I wanted to share some findings from our own group. And what we tried to do is to measure biomarkers in tear fluid using a Schirmer strip, which we insert into the lateral portion of the eye. And what we found is that potentially there may be 10 proteins that can distinguish children with JAA who do not have uveitis to those with uveitis. And these are associated with the retinal pigment epithelium and the blood-retinal barrier. And this work will be presented at ARVO in the spring. Some studies, although not as many, have looked at potentially the association with low vitamin D and the presence of allergies. And as we think about screening in children and knowing that the first 5 years are the highest risk, what we found in this study by Ellen Nordal's group in Norway is that even in the first 8 years of follow-up, 20% of individuals with JAA still develop uveitis. And when they followed these individuals and looked at the time frame between 8 to 18 years, almost 3% were still developing uveitis, which leads us to have to consider that even when a child with JAA grows up and is further away from that JAA diagnosis, annual screening may still be important so they can still develop uveitis. I think most important, what we need to try to think about is whether, with all these risk factors and improved screening, are uveitis outcomes actually improving? So looking at studies before 1990 and after, we do see that ocular complications have decreased from 75 to 50%, vision impairment from 66 to 30%, and blindness from 38 to 25%. And we think this may be due to improved awareness that uveitis occurs with JIA, that there are now better screening paradigms that are being followed. There are more effective medications, especially with availability of TNF inhibitors, and there has been improved collaboration between rheumatologists and ophthalmologists. I think we would still agree that this prevalence of complications and impairment is still too high. So thinking about that, overall, we need to consider that estimating the risk for uveitis may be helpful in improving outcomes, that children need to have regular ophthalmic screening and monitoring for uveitis development, and also thinking about the screening schedules. Schedules that are too frequent or unnecessary can be a burden to families and patients, but at the same time, not screening with enough frequency can increase visual morbidity, so there needs to be a balance. We all know about the known factors, the JAA category, the ANA status, the age of JAA onset, and JAA duration. We should start considering other factors such as demographics, early medication use, biomarkers, genetics, and others that may inform the screening schedule and better estimate risk. based on that recent study, screening probably needs to continue into adulthood, since some people were still developing uveitis at the 18-year mark. And the close collaboration and communication of both specialists is important so that we ensure that all children achieve optimal ocular outcomes. So back to our case briefly. So again, this 3-year-old with right knee arthritis who's ANA positive, if we think about her risk factors, we know that having oligoarthritis, ANA positivity, being less than 7 years of age, and 2 months from JI onset put her at high risk. So thus her risk is high. And the screening that would be recommended for this child based on known risk factors would be an eye exam every 3 months. And again, this is just the screening guidelines from the American Academy of Pediatrics, which is a little bit simpler. And thank you from Cincinnati, Ohio.
Bueno, muchas gracias a la doctora Sheila Angels Han.